Yourself?
I'm Dr. Shalini Agrawal, MBBS MS Ops Gynae.
I'm Dr. Neha Agrawal. I'm working as a fellow here at Ideal Fertility Center.
Today we have two very important topics, and these are one covered by Dr. Neha and another by Dr. Shalini. One is how we do ovulation induction, what our goal to get a good quality oocyte. What is good quality oocyte? What oocyte you should give to the tube during IUI or to the embryologist during IVF. And Shalini will cover another very important topic. Can we start ovulation induction with follicular phase stimulation or luteal phase stimulation? What is the comparison? Why we are doing so? Because if there is lack of time or the lady or the girl is undergoing some chemotherapeutic treatment and you don't have time, can we start in luteal phase? What will be the comparison? It is from the Fertility Sterility Journal and it is from February issue, very latest. I think you will enjoy it. Please, I request Neha to go ahead with her topic.
Thank you, sir. So, as sir already told, my topic is understanding good quality oocyte in ART. So, before delving into how a good oocyte is formed, we must know what is a good oocyte. So, the main aim of doing an IVF is formation of a healthy embryo and which results in a good pregnancy. This healthy pregnancy is the result of fusion of two germ cells. One is the egg which comes from the mother, another is the sperm which comes from the father. These two fuse to form a euploid embryo. Euploid means this has a chromosomally normal number of chromosomes, that is 2n or 46 chromosome. This euploid embryo must have minimal miscarriage rate and good implantation rate. Then it will be called a healthy embryo. So, this egg which is coming from the mother, it should be a fully mature egg capable of being fertilized, forming a high quality euploid embryo and leading to a successful pregnancy. Now, how do follicles and egg develop? As we all know, the egg comes from the follicles present in two ovaries. These follicles are in different stages of development inside the ovary. As the follicles develop, so does the egg inside them. Now let us see how the follicles develop. This diagram is showing the multiple stages of follicular development. The first stage is the primordial follicular stage, in which there is a single oocyte in the center surrounded by a squamous layer of cells. Then the next stage is the primary follicular stage, in which the oocyte acquires a layer of glycoprotein which is called as zona pellucida, and these cells convert from flat to cuboidal. Now, under the effect of FSH, this granulosa cell layer, which is the cuboidal layer, it will proliferate and form a secondary follicle. This secondary follicle further accumulates estrogen, resulting in the formation of antral follicle. This antral follicle converts to a pre-ovulatory follicle or a dominant follicle, which is also known as Graafian follicle. Now what happens in a natural cycle? There is a selection of only one dominant follicle, which after LH surge will undergo ovulation and form a corpus luteum, which will secrete progesterone. But what happens in an IVF cycle? There is selection of multiple dominant follicles and will put a needle inside this follicular fluid and aspirate around 11 to 12 number of good oocytes in a good stimulated cycle. Now, we have every lady has a fixed pool of primordial germ cells, which is formed by mitosis in the fetal stage. So the maximum number of cells are found at 20 weeks of gestation, which are around 7 million. Thereafter, this pool will gradually decrease, and at birth only 1 to 2 million of follicles are left, which further reduces to 3 lakhs at puberty, and in the whole reproductive lifespan of the lady, only about 400 to 500 eggs will ovulate. Now, what is the cause of decrease of this ovarian reserves or number of primordial follicles? This is due to continuous non-reversible depletion of the pool of primordial follicles. What happens? From birth to puberty, there is recruitment of a cohort of follicles in each cycle, and because up to puberty there are no hormones, the follicles arrest at the secondary follicular stage and maximum will die. But from puberty there will be release of hormones, which leads to the secretion of FSH and the formation of the antral follicles, and in each cycle one dominant follicle will be formed. Now, how many days are taken for this stages to be this follicle to be converted from primary to pre-ovulatory follicle? It is said that from this follicle from stage of primary to pre-antral follicle takes about 120 days. From pre-antral to antral follicle it will take 70 days, and from antral follicle to pre-ovulatory stage it will take 14 days. So, this conversion of primary follicle to the pre-ovulatory stage will occupy around 8 menstrual cycles of the woman. If we add all these 120, 70 and 14, it will come to around 205, which is 8 menstrual cycles. This means that, as I already said, a pool of follicles is selected months before menstruation, with only one becoming the dominant follicle. Since this process repeats, the ovarian reserve will keep on decreasing. Now coming to oocyte development. Before I describe about how an oocyte develops, it is necessary to know something about cell division. So there are 2 types of cell division. One is mitosis and the other is meiosis. In mitosis, what happens? The parent cells divide into 2 daughter cells with the same number of chromosomes. And in meiosis, the parent cell will divide into 4 daughter cells with half the number of chromosomes. The main aim of meiosis is to get a germ cell with half the number of chromosomes. So when 2 germ cells combine, they can complete the set, that is 2n number of chromosomes. Now I will be talking in short about meiosis. So the meiosis is divided into 2 sequential divisions, meiosis 1 and the meiosis 2. Meiosis 1 has 4 stages: prophase 1, metaphase, anaphase 1 and telophase 1. In prophase 1, the chromosomes will condense. In metaphase 1, these chromosomes will come in the center of the cell at the metaphyseal plate. In anaphase 1 phase, these chromatids, sister chromatids will separate and go to the different poles, to opposite poles of the cell. And in telophase 1, there will be the formation of nuclear membrane. Further, followed by cytokinosis, means division of the cytoplasm. Then, in what we are seeing in meiosis 1, the chromosome number is decreasing to half, from 2n to n. Then meiosis 2 occurs, in which the chromosome number will be same. It is just like mitosis. It also has 4 stages, from prophase 2, metaphase 2, anaphase 2 and telophase 2. And finally, there will be a formation of 4 haploid number of cells. Now, oogenesis is also a form of meiosis. So the oogonium has two n number of chromosomes, that is 46 number of chromosomes. This will undergo mitosis and will form a number of daughter oogonium, which will grow to form a primary oocyte. So up till puberty, the primary oocyte is arrested at prophase 1 of meiosis 1, and after fertilization, the second stage of meiosis will be completed. So as I already said, meiosis 1 is completed before ovulation, meiosis 2 is arrested at metaphase 2, and fertilization triggers the completion. This is the summary of what I already told, the formation of oogonium and the progression of the oocyte from primary oocyte to the secondary oocyte stage, and then completion of meiosis 2 after fertilization. Now, before knowing about what is a good oocyte, we must know how a good oocyte looks like, which is called as morphology. That is how a good oocyte looks under the microscope. So this is the picture of the oocyte. The outer layer is called as zona pellucida, which acts as a protecting layer of the egg. Then inside there is egg, and the space between the egg and the zona pellucida is called as perivitrinine space. After the completion of meiosis 1, there will be excretion of a polar body, which we can see in between the egg and the zona pellucida. Now coming to the stages of egg development. So this germinal vesicle stage is the egg which is arrested in prophase 1 of meiosis, here. In this stage. In this stage, nucleus is present. So in germinal vesicle stage, there will be presence of nucleus, and it is an immature egg. Now, the next is M1 stage of the metaphase 1. In this, nucleus is not there, neither is the polar body. So both nucleus and the polar body are not there. So these eggs are also immature, but they may mature in the lab. The next is the M2 egg, which is the best egg for IVF. It has a polar body, it is fully mature and ready for fertilization. These are the eggs which we are using for IVF and ICSI. So this figure is describing the same thing which I told, the germinal vesicle stage, the metaphase 1 stage and the metaphase 2 stage. In germinal vesicle stage, there we can see a nucleus. In metaphase 1 stage, polar body is also not seen, neither is the nucleus. In metaphase 2 stage, a polar body is seen. So, finally coming to the definition of M2 oocyte, which is, as I said, best oocyte for IVF. It is an oocyte arrested in metaphase 2 with the presence of a first polar body and with a fully mature cytoplasm. What are the key morphological features under the microscope of this oocyte? Presence of first polar body, clear cytoplasm with a well-defined perivitrinine space, and a smooth regular appearance, and a healthy surrounding cells. This egg is surrounded by a layer of cumulus cell. So the surrounding cumulus cells should show expansion, often indicating that the oocyte has received appropriate signals for maturation. And there should be absence of abnormalities like high cytoplasmic granularity, large vacuoles or fragmentation. Now, what is the clinical significance of this M2 oocyte in IVF? This is the oocyte which has a higher fertilization potential, improved embryo development and higher success rate. Now coming to nuclear maturity versus cytoplasmic maturity. So the nuclear component of the egg involves the chromosome and the DNA. And this oocyte matures after the trigger shot is given or after LH surge in the natural cycle. This triggers meiosis to resume. So if there is a presence of polar body, the nuclear component has matured. Now this cytoplasmic component is a bit tricky. We cannot predict if the cytoplasm is mature or not, because we cannot see what's happening inside the cytoplasm under a microscope. So these both components, nuclear and cytoplasmic maturity, is required for a proper euploid embryo development. Now, what is the effect of follicle size on egg quality? So naturally, the follicles which are coming from the eggs which are coming from bigger follicles, they will be of better quality. But here there is a trick. When the follicles get too large, if they are more than 23 mm, this can lead to a post-mature oocyte. This means large follicles are good, but they should not be more than 23 mm. If they are more than 23 mm, this will lead to reduced quality and degeneration after ICSI or after a natural fertilization. So what is the relation between advanced maternal age and egg quality? So as we all know, with increasing age, the pool of eggs will decrease and the miscarriage rate will also increase. Why the miscarriage rate is increasing? Because the chromosome will acquire aneuploidy. That is, during the metaphase stage of meiosis 1, there will be the crossing over. During crossing over, non-disjunction will be there. So, in women less than 35 years, 60% of the embryo will be euploid. But if the patient is 44 years, only 10% will be euploid. Now genetics and egg quality. So there is a thing called embryonic gene activation. This embryonic gene activation does not occur until 3 days of fertilization. So up to 3 days of fertilization, the embryo is depending on the cytoplasm of the oocyte for the nutrients. So if the embryonic gene activation does not occur, the embryo will degenerate. So this embryonic gene activation is mostly coded by the maternal effect genes, that is the genes inside the egg of the mother. Now, relation between egg quality and diminished ovarian reserve. So, if the ovarian reserve is less, then the quantity of the eggs retrieved will be less, but there will be no effect on the quality of the egg. Second is the endometriosis. In endometriosis, there is no difference in the live birth age, but there will be lower implantation rate and fewer eggs will be retrieved. And in PCOS or polycystic ovarian disease, more eggs will be retrieved, but they will be immature, and which will lead to lower fertilization, more miscarriage. Now, what is the relation between lifestyle factors like smoking and alcohol and the egg quality? So, it is important to know that both smoking and alcohol leads to more miscarriage rate because of abnormal egg morphology. Some diets favor increase the egg quality, which are fruits, vegetables, whole grains, nuts, and consumption of milk, dairy, legumes, vegetable, and fish. So these have been seen to increase the quality of the oocyte and a normal egg morphology. And in contrast, the consumption of refined sugar and artificial sweeteners, they will increase the abnormal egg morphology and decrease in the pregnancy or live birth. Now coming to the supplements. These days in IVF we give lot of supplements for increasing the egg quality, which may be vitamins, mineral, herbs, but till date there is no conclusive study about their positive effect on the egg quality. So in conclusion, folliculogenesis and oogenesis both are tightly coordinated processes essential for producing a competent oocyte. A good oocyte is a oocyte which has a completion of nuclear maturation and optimal cytoplasmic maturation. Morphological features will correlate with the developmental potential, that is a clear cytoplasm and a visible first polar body. And if there is any error during meiosis, this can lead to aneuploidy. So the take-home message is a good M2 oocyte is the culmination of precise endocrine regulation, flawless meiosis, and optimal follicular development. That is, the level of hormones should be good, endocrine regulation, flawless meiosis, there should be no non-disjunction or inadequate separation of the chromosomes, and optimal follicular development. That is, the follicles should support the growth of the oocyte. Thank you.
Thank you, Neha, for your wonderful talk. And why we have kept this talk for her, because we are doing ovulation induction, we are doing IUI, we are doing IVF ICSI. So the things are, as a clinician, what is our role? We are manipulating a normally menstruating woman who is producing a single good quality egg. But we need more good quality egg. So if we interfere with the normal menstrual cycle, so that we do that stimulation, or we should do any induction or manipulation, whatever quality of the oocyte the tube is getting during IUI or embryologist is getting during IVF, it is our responsibility that how we modify or monitor or induce the regular menstrual cycle, or in PCOS, or having a very good control over hormonal milieu, so that you can get good number of oocyte. That is not enough. They should be of good quality of oocyte. If you give too many number of GB oocyte to your embryologist or to the fallopian tube during IUI, will they conceive? They will not conceive. They will not make good embryos. So this talk is very important for her, because we want that our embryologist should get good M2 oocyte. Or if you are doing a IUI cycle, then
the fallopian
tube should get a good M2 oocyte. Thank you very much. Now I call Shalini for her. It is a journal discussion with a brief idea of what is now in we are with luteal phase stimulation. Why it happens? Because what nowadays we are doing double stimulation, dual stimulation, or Shanghai protocol. So in dual stimulation we do luteal phase stimulation. So one paper is there whether in a normal responders, if we do follicular phase stimulation and luteal phase stimulation, what will happen? Shalini will disclose the fact which is given in the journal. Thank
Hello
you.
everyone, I am Dr. Shalini Agrawal. Today I am presenting an article from a journal, Fertility and Sterility, Fertile and Sterile, Volume 125. To the top, with the title of this article is Similar Outcome, Different Timing, Luteal versus Follicular Stimulation in vitro fertilization. So what is the objective of this article? Why we are reading this article and why we are emphasizing this topic so much? To compare the impact of luteal phase ovarian stimulation on the embryo count, embryoploidy and embryo quality with that of follicular phase of stimulation. ये जो आज का वीडियो है ये स्पेशली उन लोगों के लिए है जो हमारे कैंसर पेशेंट्स होते हैं, जो हमारी ओपीडी में आके बोलते हैं कि मैडम हमें बहुत जल्दी अपना कैंसर का ट्रीटमेंट स्टार्ट करवाना है, हमें कीमोथेरेपी स्टार्ट करवाना है। तो हम उनको बोलते हैं कि आप डे 2 पे आइए. डे 2 पे आने हम क्यों बोलते हैं? बिकॉज वी हैव टू स्टार्ट अ IVF साइकिल और वी हैव टू स्टिमुलेट पर्सन टू इन फॉलिकुलर फेज स्टार्ट फ्रॉम द डे 2 और डे 3. तो इससे क्या होता है, उनका जो ट्रीटमेंट होता है वो डिले होता जाता है. इफ वी स्टिमुलेट इन डे 2 और डे 3 एंड द रिजल्ट इज इफ वी गेट लेस ओवर, देन वी विल कॉल देम अगेन इन डे 2 और डे 3 व्हेन वी स्टिमुलेट again. But then why we are not stimulating that person, that female on luteal phase? सबसे पहला क्वेश्चन, अगर हम luteal phase में स्टिमुलेट करते हैं तो क्या ओवा बनेंगे? फर्स्ट क्वेश्चन, क्या ओवा उस साइज तक बनेगा कि वो ओव्यूलेट कर पाए, या हम और वी गेट गुड एम्ब्रियो और वी गेट गुड बर्थ. सो the question is, does starting of stitule in the luteal phase hurts embryo quality or genetic health? So first we start with the what is follicular phase stimulation. Stimulation start from the follicular phase of cycle called follicular phase stimulation. Then what is luteal phase stimulation? Luteal phase stimulation is start stimulation after the ovulation. Like if we see, this is day 1, this is day 14, this is day 28. Okay, if we'll start stimulation from day 2 or day 3 in follicular phase stimulation, and if we'll start stimulation from here after the ovulation, it's called luteal phase stimulation. But the important thing is this, it should be before pregnancy or it should be before luteal, it should be before expected bleeding. So what is the protocol of follicular phase stimulation and luteal phase stimulation? In follicular phase stimulation, we start stimulation on day 2 and on day 3, and from day 5 we start GnRH antagonist till oocyte final maturation. This is called follicular phase stimulation. In luteal phase, we have to do serum progesterone level. If serum progesterone level is more than 1.5, it means ovulation is already occurred. And the second, we also have to check her beta hCG level. Either she is pregnant or not. If she is non-pregnant and progesterone level is more than 1.5 nanogram per ml, then we'll start luteal phase stimulation. And we start like this only. For the day 1 is we stimulate it's called day 1, and after day 5 we start GnRH antagonist till the oocyte final maturation occurred. So what is the importance of luteal phase stimulation? First, स्टिमुलेशन हैड टू बिगिन एज सुन एज पॉसिबल. जैसे ही हमारे पास पेशेंट आया, हमें उसको बोलने की ज़रूरत नहीं है कि आप रुको, पहले डे 2 पे आओ, उसके बाद हम आपका स्टिमुलेशन करेंगे. हमें उसको ये बोलने की ज़रूरत नहीं है कि अपने कीमोथेरेपी या जो भी ट्रीटमेंट आप लेना चाहते हो उसके लिए आपको थोड़ा रुकना पड़ेगा, क्योंकि हम ल्यूटियल फेज, फॉलिकुलर फेज, किसी भी फेज में स्टिमुलेशन स्टार्ट कर सकते हैं. तो स्टिमुलेशन हैज टू बिगिन एज सुन एज पॉसिबल. Poor ovarian reserve. If person have poor ovarian reserve, we can stimulate her on follicular phase also and luteal phase also. Then we can get more number of oocytes. So for this, in this article, they do retrospective cohort study. They do 3,525 follicular stimulation and 552 luteal stimulation, and they compare this. So the result we get is median count of cumulus oocyte complex, mature M2 oocytes and fertilized oocytes, total biopsied and euploid blastocysts are the same. जो हमें follicular phase में मिली वही हमें same quality, same number हमें luteal phase में मिली. The minute difference is that the duration was longer and the dose was slightly higher than the follicular phase. Here I want to discuss about what is follicular wave and what is progesterone protection. So there is only one wave, because we only focus about this one wave. which ovulate on 14th day. There is a simultaneously other wave of the follicular growth. If we will stimulate this follicle, these follicles, after the ovulation, these follicles can, because there is no only one cohort of the follicles. There are waves, like this goes like a wave. First, these follicles stimulate, then these follicles come here. If will not stimulate here these follicles, they will go in atresia. So we can stimulate these follicles here and get a more number of oocytes. So what is follicular wave? The study supported that wave theory. The follicles are available for recruitment throughout the entire cycle, not just at the start. The second thing is progesterone protection. High natural progesterone in luteal phase may naturally prevent premature ovulation, acting as a built-in blocker similar to medication. We can see this progesterone level is higher in follicular phase. So if progesterone is high, LH will not increase. If LH will not increase, there is a no ovulation. So this raised progesterone help us to block ovulation.
That means you don't fear with premature LH surge,
Yeah.
or you don't have to require for GnRH antagonist.
Yes, sir, and we should not fear, because there is some people think about कि in follicular phase there is a no progesterone, but in luteal phase there is a raised progesterone. So there is a fear कि if oocyte will grow or not, what will the progesterone affect in luteal phase on the oocytes. So it will help not.
But this has been shown that what you are putting, that even though the follicular phase, this luteal phase progesterone is so high, you are utilizing the second wave of the follicles to stimulate them with your gonadotropins,
Yes, sir.
without any fear of premature LH surge, which is a fear in follicular phase, because there is a high amount of progesterone which is inbuilt by corpus luteum. I think this is what they are. So in our dual stimulation also,
Yes, sir.
we use GnRH antagonist
Yes, sir.
in follicular phase. But if in the same cycle, if we do the luteal phase,
Yes, sir.
what we do is that there is a fear in luteal phase that if it goes little bit longer, then patient may menstruate, because your previous progesterone might fall.
Yes, sir.
If she menstruate, then at the time of ovulation,
Yes, sir.
or at the time of your ovum pickup, patient might be bleeding.
Yes, sir.
So what you feel that what we should do? Either the natural progesterone should continue. If it is not continuing, then you can put her on artificial progesterone.
Sir. We can give progesterone vaginally or orally.
Orally we can
Yes,
give,
yeah.
until you are doing the ovum pickup of the luteal phase.
Yes,
This
sir.
can be
Till the ovum mature, we can give the progesterone externally. It will block the LH surge and there is no ovulation.
So that means if you start with progesterone in the luteal phase,
Yes, sir.
with stimulation,
Yes, sir.
then two things you are avoiding. One is premature LH surge,
Yes, sir.
and second, after 14 days, what she is going to menstruate, she will not menstruate.
Yes, sir.
And it has been established that if we use progesterone in follicular phase also,
Yes, sir.
if we use progesterone from day
follicular
2,
phase. Yes, sir.
that is progesterone primed ovulation protocol,
Yes, sir.
then you don't have to use again cetrorelix, that is GnRH
Yes, sir. On
antagonist,
day 5 we cannot.
because there will not be any.
Requirement, sir.
So medroxyprogesterone is a cheaper alternative of cetrorelix.
Bilkul, sir.
So same thing has been used in follicular phase.
Yes.
You can do it in
Luteal phase.
luteal phase also.
Yes. So conclusion of this article is luteal phase stimulation is a safe and effective alternative. It does not negatively impact embryo quality or genetic health. The trade-off is a slightly higher cost, more medicines and one extra day of treatment. Thank you.
I think this is one of the very important method of controlling the ovarian stimulation, and this paper has given a robust idea that follicular phase stimulation, what we do in poor ovarian reserve or in the girls who are undergoing chemotherapy as early as possible and they don't have time to wait for the next day 2 of the next cycle. So there is evidence that if the luteal phase stimulation can be done, the same amount of eggs, same
Yes.
quality of eggs, same number of blastocyst and same number of euploid blastocyst if you do biopsy.
Yes, sir.
So that means if you don't have, or the lady or the girl who is not going to stay in your city for long, not undergoing chemotherapy, but she wants an IVF and wants to pool her. The only problem is that with this protocol you cannot do the fresh embryo
Yes.
transfer. So you need a frozen embryo transfer. So what we are doing is now, because our embryo freezing is so robust,
Yes.
madam is doing such a good embryo freezing.
Yes, sir.
So we don't have any fear that whether blastocyst will be revived or not.
Yes.
Most of the time they are revived, and we are doing now this embryo biopsy also and euploid screening also. So we can get good number of blastocysts which are euploid, and the number is almost same with
Yes.
follicular. And
In both phases, number are same.
so it is a paradigm shift of thought process,
Yeah, sir.
Whatever we have read in our date, Ashita bhi बैठी है, whatever we have read in our day-to-day throughout college days and all, कि आप सेकेंड डे या थर्ड डे से ल्यूट्रिजोल दो या स्टिमुलेट करो, सब करो, बट अब यही काम डे 14 डे 15 से भी कर सकते हो, इवन विद द लेट्रोजोल कर सकते हो. कोई जरूरी नहीं कि आप कोनोट्रोपी नहीं
Yes, sir. जो मेडिकेशन अपन फॉलिकल फेज में यूज कर रहे हैं वही हमने कोई लुटियल फेज में यूज करते हैं. वी कैन स्टार्ट विद द लेट्रोजोल आल्सो, सर. तो ऐसा हो जाता है.
बट द थिंग इज यू कैन नॉट डू IUI विद दिस.
Yes, sir.
You have to do IVF with this, and you cannot do fresh embryo transfer.
Yes, sir.
But one thing is very clear, that you can accumulate high number of
Egg number.
pooling कर सकते हैं, और high number of euploid blastocyst का pooling कर सकते हैं.
ये सर जैसे जिनके लो AMH वाले पेशेंट होते हैं, जिनके फॉलिकुलर काउंट्स कम है, उनको कई बार क्या होता है कि एक स्टिमुलेशन में एक फॉलिकुलर फेज में हमने स्टिमुलेट किया, कम आए, एक ही 2 ओवा हमें मिले, तो बहुत मुश्किल होती है वो 1-2 ओवा सेव करने में, पेशेंट को करें. तो उसी साइकिल में हम उसको ओवा रिट्रीव करने के बाद फिर से स्टिमुलेट करते
Yes.
हैं, तो वो कम से कम हमारे पास 5-6 तो हो जाए, सर.
So this is a जो पहले हम एक पढ़ते आए हैं, और जो एक कन्वेंशनल एक विजडम है कि आप डे 5 के बाद स्टिमुलेट नहीं कर सकते.
Yes, sir.
तो फॉलिकुलर फेज में नहीं कर सकते, पर यदि वो ल्यूटियल फेज में आ जाती है और डे 14-15 में आ जाती है और उसका ओव्यूलेशन प्रीवियस वाला हो जाता है,
Yes, sir.
देन यू कैन हैव अनदर स्टिमुलेशन इन अ
Yes, sir.
luteal phase also. Thank you very much for joining us. This video will be in our YouTube channel. Whenever you get time, they have given a very nice overview of this. Thank you very much. Thank you, Ms.Ishani.